Good afternoon, one and all, and a very warm welcome to one and all present here. I, Dr. Navya N., Assistant Professor in the Department of Community Medicine, Yenepoya Medical College, welcome you for the guest lecture on the occasion of World AIDS Day 2020. So I'll just briefly go through few instructions. Kindly mute your audio and switch off your video. Questions will be discussed at the end of the guest lecture. You can submit your queries and doubts in the chat box section. At the end of the program, a feedback form will be shared in the chat box of Google Meet and comment section of YouTube platform. So kindly fill this feedback form, following which you will receive an e-certificate to your email address mentioned in the feedback form. I would now like to request Dr. Poonam R. Naik, Professor and Head, Department of Community Medicine, to deliver the welcome address.
Thank you, Dr. Navya. Good afternoon to all. Department of Community Medicine, Yenepoya Medical College is organizing this webinar on occasion of World AIDS Day 2020 with guest lecture on elimination of mother-to-child transmission of HIV. World AIDS Day 2020 calls on for global solidarity from the leaders and citizens and actions to be taken to overcome the challenges posed by the dual burden of HIV and COVID-19. And we, as healthcare professionals, have a major role to play. We are pleased to mention that we have received registrations from various government and private academic institutions and also healthcare organizations from all over the country, representing all the 4 zones, which includes not only the different districts of Karnataka, but also the states of Andhra Pradesh, Telangana, Kerala, Puducherry, Mumbai, Orissa, Chhattisgarh, and Uttarakhand. So we are overwhelmed by this registration from the participants all over. On this occasion, we have with us Dr. S. Padmanabha, Medical Superintendent, Yenepoya Medical College Hospital. Sir has taken a lead role in the well-functioning of Yenepoya Medical College Hospital, more so in the COVID-19 times. It is a pleasure to have you with us on this occasion, sir. We welcome you, sir. It's our privilege to have with us for this guest lecture Dr. Lalita Hande, State UNICEF Consultant, Government of Karnataka for Prevention of Parent-to-Child Transmission and Maternal Health. Dr. Lalita, with your immense experience in public health and especially in PPTCT program and maternal health, we are sure that your session would be of paramount importance to our participants. I welcome you, Dr. Lalita. I also welcome the Associate Dean, Yenepoya Medical College, Dr. Abhay Nirgude, for this webinar. I welcome all the senior faculty, heads of the departments, dear colleagues, and all the participants on this occasion. Dr. Navya N., Assistant Professor and Coordinator of today's program, I welcome you. Wishing you all a happy learning. Thank you.
Thank you, Madam. We now begin with the sessions. The first session is by Dr. S. Padmanabha, Medical Superintendent, Yenepoya Medical College Hospital. Dr. Sampatila Padmanabha, who is a MD DNB in anesthesiology, is presently working as Medical Superintendent of Yenepoya Medical College Hospital of Yenepoya deemed to be university. Sir has more than 30 years of undergraduate and postgraduate teaching experience and more than 35 years of clinical experience in anesthesiology. Sir has more than 30 publications and more than 40 presentations in various national and international conferences. He has been secretary and president of various professional bodies of anesthesiology. It is a proud privilege to mention that under his leadership, Yenepoya Medical College Hospital has been awarded for its measures taken for safety of the health staff and recognized for its role in care of COVID patients. I would now like to request Dr. S. Padmanabha to give the opening remarks on the program.
Thank you, madam, for that nice introduction. Hope you can hear me.
Yes, sir, you're audible.
Yes, sir, you are audible.
Yeah. Good afternoon. Respected our chief resource person today, Mrs. Lalita Hande, who is a maternal health consultant, UNICEF, Karnataka State Government, HOD, Department of Community Medicine, Dr. Poonam Naik, and our earlier former HOD Community Medicine, and presently the Vice Dean, Dr. Abhay Nakude, all the faculty members of the Community Department, postgraduate students, undergraduate students, ladies and gentlemen. It is my pleasure to be part of your program as you are celebrating the World AIDS Day program. Actually, the World AIDS Day program actually on 1st December, but the whole December we can celebrate and disperse our knowledge regarding AIDS, how to prevent, how to control this deadly disease. Like our COVID-19 disease, when in 1980, the HIV, when it has come into this world, people were really afraid, and the person who was affected with the HIV is given like a passport to go from this world. That was the situation in 1980, and I remember that one of the patient who is a doctor himself, and when he died of HIV, not only the area but also the school where his children were studying were removed from that place, and the benches which the students his children used to sit also burnt out. That was the situation at that time in 1980. Later on, as we moved our program in controlling the disease, knowing about the disease, people have understood what exactly the HIV, and people were able to live with the disease. And today we know that HIV can transmit mainly by 4 routes. One is unsafe sexual practice. Second is by blood transfusion, which is also unsafe if it is done. Third is by the unpracticed injections or self-injections, like those who are taking drugs. And lastly, the HIV can transmit from mother to the fetus. So today, the madam will focus mainly on the how to control this transmission from mother to the child. And even if the mother is HIV positive, how to prevent when the child borns, what are the drugs we have to give to the child, and how to take care, which one will be elaborated by our resource person today. So like COVID, there is a social stigma for people who are affected with this disease. So what we have done in our hospital is, we did not do any separate isolation being for HIV patients. They are kept in the same ward like any other patients. And we will not disclose to other patients about this person who has infected with HIV. We always take consent before undertaking the test for HIV. And in all our blood transfusion practice, we do conduct the HIV test before we subject this blood to be given to another person. And whenever there is an accidental pinprick to any healthcare worker, we have designated few doctors from the medicine department, and immediately this person, any kind of healthcare worker, whether it may be paramedical people or the postgraduate students or medical staff, immediately will consult that team of doctors, and according to the advice, we will proceed for testing as well as taking of the tablet ZOVD. And we always practice the universal precaution in our hospital in preventing this problematic disease. And if there is any suspected HIV patient coming for any surgery, we use always a special kit for the staff to protect themselves. And we always consider any patient who comes to our operation theater, otherwise not proved also, we should take all precautions of the staff as far as this infection is concerned. So I congratulate Dr. Poonam Madam for organizing this difficult topic to all our postgraduates and other consultants, how to control this disease as well as how to prevent this disease and how to prevent the transmission from the mother to the child. So I'm very glad to be along with you in this venture of the guest lecture, and I hope this will be a useful topic to all of us. Thank you, sir. Thank you, one and all.
Thank you, sir. I would now request Dr. Poonam R. Naik, Professor at Department of Community Medicine, to give a special lecture on the World AIDS Day theme. Over to you, madam.
Yeah, thank you, Navya. I'll share my presentation firstly. I hope I am audible. Good afternoon, all.
Yes, ma'am.
Yeah, thank you, Navya. So, good afternoon, all, and welcome to the session. So, this particular session will be focusing on our role and the different actions that has been put across for observation of World AIDS Day 2020 in this particular regard. So, the session would be covering about the background, the current scenario, especially in the context of COVID-19 and HIV. World AIDS Day 2020, under the subheadings of what are the different key actions that have been proposed, intersectoral coordination and the intervention strategies, and take-home message. As we all know, HIV continues to be a major global public health issue, having claimed almost 33 million lives so far. An estimated 38 million people were living with HIV at the end of 2019, and there were more than 69,000 new HIV infections and around 58,000 AIDS-related deaths reported in India in 2019. We all know that the global HIV epidemic is not over and also may be accelerating during the COVID-19 pandemic. As we understand, with the emergence of COVID-19 pandemic, there is a breakdown in the essential HIV services, which could be because of various reasons in terms of allocation of resources or interrupted supply of medicines or economic crisis or even mobility or travel restrictions. WHO and UNAIDS modeling study has reported a 6-month disruption in access to HIV medicines could lead to a doubling in AIDS-related deaths in sub-Saharan Africa in 2020 alone, and this is an alarming figure. As a result, the world will be missing the 90-90-90 targets for 2020. Dr. Lalita will be elaborating on the 90-90-90 targets, so I won't be explaining about this over here at this stage. However, missing these intermediate targets will make it more difficult for us to achieve the end of AIDS by 2030. As we all understand, World AIDS Day is observed every year on 1st of December with a specific theme so that we prioritize and mobilize all the resources and plan our actions towards the particular theme and particular area. World AIDS Day, founded in 1988, was the first ever global health day that was observed. Observation of this day gives an opportunity for the people worldwide to unite in the fight against HIV and to show our support for the people living with HIV. On occasion of World AIDS Day 2020, World Health Organization is calling on the global leaders and citizens to rally for global solidarity so that we are able to overcome the challenges posed by COVID-19 on the HIV response. The key actions that are proposed on occasion of World AIDS Day 2020 are: renew the fight to end AIDS. As we understand, the global AIDS response in scenario of COVID-19 has been slowed down, so it's now time that we invest to innovate the HIV services with broader healthcare. It is essential to use innovative HIV services to ensure continuum of care to all those living with HIV/AIDS, and WHO has recommended multi-month prescription of HIV medicines in view of this. Engaging and protecting the frontline workers, the healthcare professionals in the service delivery, and at the same time also empowering them is essential if we have to implement certain strategies. Prioritize the vulnerable youth and key population and ensure implementation of appropriate interventions for these vulnerable groups. So these are the 4 key actions that have been proposed. Intersectoral coordination or involvement of different sectors. We all understand intersectoral coordination is one of the key principles for effective and efficient healthcare delivery, and which has also been put across in this theme. Involvement of the health workers in advocacy, in empowering the grassroots level workers, involvement of ministries of health and public health leaders, community engagement, as we understand, is the key step or is the cornerstone of all community activities, especially when it comes to combat stigma and discrimination for those people living with HIV/AIDS and in the community. We need their support at each and every step. Important role of HIV program managers, and this is reflected from the fact that today we have with us Dr. Lalita Hande, who is the UNICEF consultant for the government of Karnataka for the PPT-CT program, and various development partners so as to ensure effective service delivery both from the private or the non-government sectors as well. So with this intersectoral coordination, the strategies are: we need to advocate and ensure appropriate resource allocation for delivery of high quality essential HIV services during the COVID-19 pandemic. Combating stigma and discrimination both in the healthcare institutions and in the community level is of paramount importance. Regarding the healthcare workers, we need to empower them by training, by their capacity building, providing them a safe working environment, and also ensuring infection prevention and control measures at all the levels. Reaching out to key and vulnerable population so as to protect them and ensure delivery of essential services is also one of the important interventions towards ending this pandemic. The take-home message is, as public health leaders or as healthcare professionals, our role is of great importance when it comes to global solidarity, call for it, advocacy for delivery of essential HIV services, building the capacity of the healthcare workers, making them comfortable in their working environment, and ensuring the delivery of uninterrupted healthcare services. So let's take a minute to thank everyone who is working towards to end AIDS. Thank you all.
Thank you, Madam, for the very informative session. Now coming to the guest lecture by Dr. Lalita, PPT-CT and Maternal Health Consultant, UNICEF, Government of Karnataka. She is a seasoned public health professional with 18 years of rich experience in multiple international organizations, providing technical support for implementation, monitoring, and supervision of many national programs in India. Initially started as UNICEF Immunization Consultant for Haveri District of Karnataka, later took up assignment from Clinton Foundation as State Program Coordinator for Pediatric ART program for Karnataka initially and then as Regional Program Manager for 5 states, that is Karnataka, Andhra Pradesh, Kerala, Tamil Nadu and Orissa. Further elevated as National Program Manager, India for Pediatric ART program in Clinton Foundation. She is currently working as PPTCT and Maternal Health Consultant from UNICEF for Karnataka State since 2012. It is my great privilege to invite Dr. Lalita Hande, who will be talking on the topic Elimination of Mother to Child Transmission of HIV. Over to you, Madam.
Is my slide visible? Is my slide visible?
Ma'am, your screen is visible, but I cannot see the slide. Yes, ma'am. Now it is visible.
Okay. Thank you so much, Navya. Thank you, everybody, for inviting me. And I'm extremely honored to be present in amidst you with regard to talking to you with regard to elimination of mother-to-child transmission of HIV. And to start with, I'll give you a brief background of the HIV/AIDS epidemic in the country and in the world. In 81, the first case of HIV/AIDS was discovered, and the virus was identified in 83 by Gallo. And the first case was identified in India by Suniti Solomon in 1986. And a National AIDS Control Organization was established in the year 1992. And our program, Prevention of Parent-to-Child Transmission of HIV program, was started in the year 2002. And there were so many other centers which cropped up. Like, for example, initially to start with, we had Voluntary Counseling and Testing Services Center, VCTC centers. Then finally, they were upgraded to Integrated Counseling and Testing Centers in 2002 onwards. And by the year 2004, we initiated the ERT centers and ERT program in the country. Now, coming to the evolution of India's National AIDS program, as we all know, we are having National AIDS NACP 1, 2, 3, 4, and we have the extension of NACP 4 from 2017 to 20, and we have the National Strategic Plan. And you can see in the slide, from every 5 years, we have the different, national NACP 1, 2, 3, and 4th and extensions. And you can see the initial interventions in NACP 1, followed by decentralization to the states in NACP 2, and we had limited coverage of services, especially during 1999 to 2006. And there was a launch of treatment of services in 2004, as I said in the previous slide. We had the starting of the RT services then. And slowly the district focus gained momentum. There was a massive scale up with the quality assurance mechanisms. And we consolidated the gains in 2012 and 17. And in NACP 4 from 2017 to 20, we are committed to make concrete progress towards end of AIDS by 2030. And we have the test and treat mechanism. As soon as the positive member is detected to be, is detected at the ICTC center, he or she would be treated as early as possible. And we have the HIV/AIDS Prevention and Control Act, and we have the universalization of testing and testing of HIV and syphilis among pregnant women. And now coming to the NSP, National Strategic Plan of 2017 to 24, our goal is to end the AIDS epidemic as a public health threat by 2030. And the main objectives are, or envisaged are, 80% reduction in the HIV, new HIV infections, and as Poonam said, 1990, that is 90% of those who are HIV positive should know their status, and 90% of them
who know the status should be placed on ERT or placed on treatment, and 90% of those who have availed treatment should have got their viral suppressed. So next is elimination of mother-to-child transmission of HIV and elimination of stigma and discrimination. Now, these are the strategies of National AIDS Control Program. We have the 5-pronged strategies. One is prevention, the other is care and support, the third one is institutional strengthening and strategic information management system, and cross-cutting is IEC. So prevention, as we all know, we have targeted interventions. We look at the high-risk groups, MSMs, FSWs, and we test them and treat them as early as possible. And we have HIV counseling and testing services at the ICTC the ICTC centers. We have prevention of parent-to-child transmission of HIV. We have blood safety, and we have STA, RTA management, and also condom promotion. And these are the preventive measures which are supporting the NSCP program. And we do have care and support treatment program, like first line of ERT, second and third line of ERT treatment. We do have opportunistic infection management and HIV/TB coordination, mechanisms. We do have early infant diagnosis, which I'll be touched base upon later on in my next slides. And we do have lab services, strengthening of quality management and stuff like that. And we do have institutional strengthening, like we do have SACS, States AIDS Control Services or units. We have DAPQ units. We have the district TB officers are redesignated as DAPQ officers. We have technical support units. We have centers of excellence, especially Bowring and Eddie Cousin Hospital, or is called as the Adult ART Center of Excellence, whereas Indira Gandhi Institute of Child Health is the Pediatric Center of Excellence, and we have certain research institutions like NIMANS and other bodies. And we have strategic information management, like program monitoring and evaluation, epidemic monitoring, research and evaluation, and data analysis and dissemination. And IEC plays a very critical component in all the other prongs. Now, coming to the summary of the HIV epidemic. So I will not concentrate on global and Indian scenario. I'll be talking more on Karnataka scenario. We have approximately 2,69,470 people living with HIV, and our prevalence is 0.24, which ranges from 0.37 to 0.59%. And last year we detected somewhere around 1,015 positive pregnant women and 15,685 general clients. And the range is given as 700 to 1390 for pregnant women and 12,000 to 18,000 for the general client. And we had somewhere approximately 6,390 deaths past year. And 62.8% of the people living with HIV are on ART. And our PMTCT need, that is 1,390 positive pregnant women, should be detected at least this year. And we had 75% decline of annual new infections since 2010, and this is the highest in the country. And our country is the third largest number of PLHIV in the world, with approximately 21.4 to 23.49 lakhs, and female contributes around 42%, and children approximately 3%. This is based on the 2017 report of UNAIDS. And when I was talking about the prevalence, we have the national HIV prevalence. This is the NACO data. And you can see 0.24% is the India prevalence, and Karnataka stands at 16th place. And we do have 0.22%. And you can just see the other states as well. So we are happy. We were in the 8th place. Now we have moved to 16th place, and we stand at 0.22%. And as I was talking to you about the declining trend, so this is the trend for India, and this is the trend for Karnataka. So you can see the red one here, from 0.8 to 0.24. There is a tangent decline in the trend, whereas we were from 1.43. We are happy to, and we feel proud to say that we are at 0.22. Now coming to the overview of service availability in Karnataka, I just want to read it because many of you in the medical colleges won't be knowing what services are available at the government facilities. So these are the facilities and these are the locations. To start with, I'll start with the primary health centers. We have facility integrated counseling and testing services, and we have PPP centers also. And we are implementing this PPP model through Swami Vivekananda Youth Movement and Sati. And we have Dr. Gautami with us in this program too, and she's helping us with regard to establishment of facility integrated counseling testing services in the private sectors. And we have 2,424 primary health centers across the state, and we have 430 PPP models or PPP centers in the state, where we have ANC services available there. We have screening for HIV, we have syphilis screening and referral linkages if they are screened to be positives. And we have standalone ICTC centers, which are located at the community health centers and taluka hospitals, district hospitals, and medical colleges hospitals. Probably all your colleges might be having the standalone ICTC centers, and we have approximately 473. This is a dynamic number which keeps changing, and we do confirmation of tests there. We have referral for ERT centers, and we do early infant diagnosis testing and referral and linkages in the standalone ICTC centers. We do have link ERT centers at the community health centers and taluka hospitals, and we have approximately 311 centers. And I'm proud to say that Karnataka is the first state to have this many number of link ERT centers in all the community health centers and the taluka hospitals, because many of the states have only the district hospitals and very few community health centers, but we have percolated down to the taluka hospitals also, where we follow up ERT for stable PLHIV on first line ERT. And we have 65 ERT centers located at the district hospitals, medical college hospitals, and designated private HIV centers, where we do pre-ERT evaluation is done, initiation of ERT is done, and we linkage them to the services and other PLHIV schemes. And we have 10 link ERT plus centers located at the district hospitals, medical college hospitals, where we do the viral load testing and we initiate them on second line ERT treatment. And as I said earlier, we do have Bowring and Lady Curzon Hospital as the Adult ERT Center of Excellence, and IG Indira Gandhi Institute of Child Health, Bangalore, as the Pediatric Center of Excellence, where we give second and third line ERT and pediatric ERT. Now, I'm just giving the brief background of all the NSCP programs and the AIDS program, and I'll come back to my topic as elimination of mother-to-child transmission of HIV later on, because when you get the background, probably you'll understand the theme better. Our goal is to achieve by 2020 is achieve treatment targets of 90-90-90, as we told you, reduce the new infection by 75%, and eliminate stigma and discrimination, and eliminate mother-to-child transmission of HIV and syphilis. But for Karnataka, this is dual elimination of HIV and syphilis, which India is looking at. But we at Karnataka, we are looking at triple elimination of HIV, syphilis, and hepatitis B. And in 2030, to end the epidemic of AIDS as per the SDG goal 3 and target 3.3. So 90-90-90, I'm just going to reiterate so that it instills into your minds. So 90% of them should be diagnosed, 90% of those diagnosed should be on treatment, and 90% of those who are on treatment should have viral suppression. So this is what it means by 90-90-90. Now, what is the current scenario when I talk about 90-90-90? As you all know, 2.14 to 2.4 million people are living with HIV and are HIV positive and they are diagnosed. 1.7 million are only diagnosed. That means to say we have not reached the first 90 itself. And when it comes to on ERT, 1.4 million, that means to say only 82% of the 1.7 million are on ERT, and 74% of them are viral suppressed or almost tested and treated. As per March 2019, this is the data. So this is, and 0.1 million comes from the private sector. So we are yet to reach our target. But again, when I talk about elimination, I will show you my slides later on, which shows you the Karnataka scenario. Now, what are those interventions which we are planning to do for achieving this 90-90-90? One, PLHIV unaware of the status, we are doing community-based testing. We are doing the index testing, especially community-based testing where the HRGs are there, FSWs are there. We are going to the community, we are doing the testing. Especially in other states, they are doing the VHSND testing. And people who are aware but not on ART, we are again testing them and treating them properly, and intensified LFU tracking, loss to follow-up tracking has been done. Very close monitoring of the positive pregnant women as well as general clients is been done. Partner testing is done. Third 90 again, how do we achieve viral load testing scale up? Right now we are only having 10 viral load testing centers in Karnataka. We are planning to scale that up in coming years, and differentiated care to improve retention and adherence. So these are the interventions which we have planned to achieve our 90-90-90 goal. Now coming to our topic, national guidelines, prevention of parent to child transmission of HIV and how do we eliminate them. So the goal is to ensure that the mother gets tested in the first trimester result. If she is found to be positive, put her on treatment as early as possible. Ensure that she adheres onto the treatment, and ensure that the child is HIV free, so that she gets a treatment as early as possible, and ensure that the child is free of HIV, and we should ensure that the mother is alive. Now, as you all know, the mother-to-child transmission can occur during pregnancy, during labor and delivery, as well as during breastfeeding. So you can see the right end picture here. For example, if I say 100 pregnant women, HIV positive women are there here. On an average, 30 babies will be infected with HIV. As you all know, the transmission rate is between 30 to 45%. So on an average, when I say that, 5 become infected during pregnancy, 15 of them become infected at the time of delivery, and 10 become infected through breastfeeding, mostly in the early weeks. So as you all see, during pregnancy, during labor and delivery, and during breastfeeding. So in the initial days before 2012, we were concentrating because we knew that only majority of the infection transmission occurred during labor and delivery. So see here we see 15 become infected at the time of delivery. So we used to give single dose nevirapine to the mother and single dose nevirapine to the child soon after delivery. So this was the strategy which we adopted, but later on the strategies changed. So I'll come back to the strategies later. What are the factors that increase the transmission of HIV? There are certain maternal factors during pregnancy. There are maternal factors during delivery, and these factors while breastfeeding. So the most common factors are the high maternal viral load, which is most important, especially new infection during pregnancy, and if the mother is having a advanced disease in the mother. And some of the other infections like viral, bacterial, and parasitic and placental infection, again, are the risk factors for transmission of HIV from mother to her child. And if maternal malnutrition, again, malnutrition plays a very important role in transmission of HIV from mother to a child. And even STI and RTA infections are the most commonest ones, which have a great role to play in transmission of infection. And some of the factors during delivery are prolonged labor and the rupture of membranes, acute chorioamnitis, invasive childbirth procedures, premature birth of the infant. And all these are very risky for the child, especially when it comes to transmission of mother to child, HIV from mother to child. While breastfeeding, again, mixed feeding and breast abscess and nipple fissures and other mastitis, all other conditions are very, very important for transmission of HIV infections. These are the 4 prongs of pipidicity. Whenever I do a presentation, this is the commonest and the most important slide of all those. So which gives you the whole gist. Not only we are talking about the prong 3, it gives an idea of all 4 prongs. When I say that primary prevention, especially we should ensure that anybody who is on the who is of the reproductive age group should not get HIV infection. So this is the prong 1, primary prevention of HIV. So we should ensure that all remain negative, and we have adolescent and reproductive and sexual health clinics in all our centers. The second prong is prevention of unintended pregnancies, especially if she intends to be pregnant. So we should ensure that she be placed on ERT as early as possible. If she does not want to continue her pregnancy, we have family planning services in the ICTC, and more importantly, a good number of counseling sessions in the ERT centers. Third prong is prevention of maternal mother-to-child transmission of HIV. So we should ensure that she get registered at the early trimester, place her on treatment, ensure that she's been followed up, she's been adhered to the treatment, and she get institutional delivery, and we should ensure that the child is being tested. And the last prong is the care and support for the mother as well as child and her family. So these are the 4 prongs of the pipidicity, and these are the pillars for this program. Coming to the risk of transmission of mother to child with ARV interventions. So these are the ARV interventions, and this is the risk of HIV transmission from mother to child. If there is no antiretroviral treatment or intervention, and if the mother is breastfeeding, the risk of transmission is 30 to 45%. If there is no ARV intervention and the mother is not breastfeeding her child, the risk of transmission is 20 to 25%. If there's a short course with 1 ARV, that is single dose nevirapine, which we used to give earlier, and breastfeeding, the risk of transmission was 15 to 25%. Short course with 1 ARV and no breastfeeding, the risk of transmission was 5 to 15%. Short course with 2 antiretroviral drugs and breastfeeding, which we did the ARV prophylaxis between 2012 to 2013, where we gave only 2 ARVs. So the risk of transmission was around 5% then. And now 3 ARVs, antiretroviral treatment with breastfeeding, the risk of transmission is 2%, and without breastfeeding, the risk of transmission is 1%. So you can just see with triple drug regimen and with breastfeeding, we can achieve our elimination goal of less than 5% and less than 2%. When I say elimination, the elimination goal is less than 5% among the breastfeeding population and less than 2% among the non-breastfeeding population. When I say Karnataka, we almost majority, 99% of them breastfeed their children. So even when I say less than 5%, again, we can achieve the elimination agenda with breastfeeding. Now, I would like to, reiterate and impress upon all these transmission rates, what happened in Karnataka and in India, and how did we go about. For example, 30 to 45% was the transmission rate when there was no intervention, which you all know before 2002, there was no publicity program, then there was no intervention. As we progressed after the intervention of the single dose nevirapine, the transmission rate was 10 to 12% and Karnataka stood at 11%. This was from 2002 to August 2012. Then we had the ARV prophylaxis where we gave the triple drug regimen for the mother, and slowly, and we continued the ARV prophylaxis till the child was 6 months of age. We gave tenofovir, lamivudine, and efavirenz for those mothers with more than 350 from 14th week of gestation. We were not giving the mother immediately, soon after she was diagnosed to be positive, but we used to wait till the CD4 was more than 350 from 14th week of gestation, till the cessation of breastfeeding. And so for lifelong ART, we used to give ART treatment for the mothers with CD4 count less than 350. And baby was given syrup nevirapine from birth to 6 weeks of age from September 2012 to December 2013. Whereas from 1st January 2014 onwards, we started the strategy test and treat, option B plus strategy, where we give lifelong triple drug regimen for the mother and yearly prophylaxis for the baby. And now the transmission rate is between 2 to 5%, and Karnataka stands at around 1.9 to 2.8%. What are the eligibility criteria? As you all know, the eligibility criteria, I test and treat when I say irrespective of the CD4 count, irrespective of the WHO clinical staging, and irrespective of the gestational age. Whenever the mother is found to be, she comes to the ANC clinic, she's tested for HIV, she's found to be positive, irrespective of the CD4 count, irrespective of the WHO clinical staging, irrespective of her gestational age, we put her on treatment. So this is the test and treat strategy which has been adopted in India as well as in Karnataka from 2014 onwards. How do these ARV drugs work? They reduce the maternal viral load to less than 1,000 copies, and we load as we give the child also on nevirapine. We put the child on nevirapine prophylaxis. We are loading the fetus with ARVs because she's already taking the ART drugs, and as soon as the child is born, the child is placed on nevirapine prophylaxis, and that prevents the transmitted virions from replicating. This is how the ARV drugs work. Now coming to the management of positive pregnant women. As I told you, the publicity program, I should really thank, we should be really grateful to late Sushma Swaraj madam, because she was the one who coined the term as prevention of parent-to-child transmission of HIV. Earlier it was called as MTCT, mother-to-child transmission of HIV. She said that why only mother is to be, nominated or designated as transmitter of infection from mother to child. So it is the father who gives the infection to the mother, and mother transmits the infection to a child. So she coined the word as PPTCT. So I remember her today. So now coming to the program per se, newly identified positive pregnant women, we give the mother on tenofovir, lamivudine, and efavirenz, TLE, 300 milligrams, 300 milligrams, and 600 milligrams. We have also started the dolutegravir regimen, TLD, from this year. So probably the guidelines might change in a couple of days. And for those women who are positive pregnant women who are exposed to non-nucleotide receptors inhibitors, non-RTIs, especially like single dose nevirapine in her previous pregnancy, but not on ART now, we give the mother on tenofovir, lamivudine, and loperamide. Excuse me. And for those non-positive pregnant women who are on ART, so they continue the same existing regimen. They will be, as a general client, they will be, they will be designated at the ART centers. And once they become pregnant, they continue the same regimen what they were continuing earlier. So this is the management of positive pregnant women. As I told you, the new pregnant woman gets tenofovir, lamivudine, efavirenz, and as I told you, TLD now. from the second trimester onwards. And for those positive pregnant women who are exposed to nevirapine in the previous pregnancy, we give TLL. And for those non-positive pregnant women who are already on ART, we continue the same regimen. But also we should ensure that who comes directly in labor, especially during in the district hospital or taluk hospital, who do not have a ICTC test result, HIV test result, then we screen them for HIV. This is done by the lab counseling by the labor room staff nurse. She does the whole blood finger prick test and she screens with consent. If the mother is found to be positive, we initiate that mother on TLE regimen and we ensure linkage to the ART center, and we inform the lab technician and the counsel of that particular ICTC center to do the confirmatory test, and we test the mother as per guidelines. Ultimately, fixed dose combination, the FDC single pill to be taken at bedtime. So this all comes in a combination fixed dose regimen. This should be taken at bedtime. So ultimately, management of positive pregnant women, essential obstetric care which is free of discrimination. ART for more than 24 weeks during pregnancy will suppress the viral load to less than 1,000 copies. So this, and we are also loading the, because of mother is taking the virus, the ART drugs, the variants will stop replicating and there won't be any transmission of HIV from mother to the mother to her child. Initiation and more than 95% adherence to ART is very critical. And we also monitor for nephrotoxicity, CNS symptoms, if there is any GI symptoms and any pancreatitis due to ART drugs. So this is about the management of pregnant women. And we also ensure that cesarean section is advised only in obstetric conditions and not for any other cause. And artificial rupture of membranes, especially instrumental deliveries, you all know increases the risk of transmission. So we avoid that. And coatermoxazole prophylaxis initiated for the mother if the CD4 count is less than 350 cells per cubic millimeter, along with the ART treatment. So this is for the mother. Now, what do we do for the child? Management of HIV exposed child. When I say HIV exposed, there are two types of children. One is the child who is born to a positive mother is the HIV exposed child. And for example, if we don't know if the child is having if the child is an orphan, or the child doesn't have any ICTC report, or if the child is having high symptoms of HIV, then we call them as exposed. And what do we do for those? Essential newborn care, which is very critical. Exclusive breastfeeding is advised from birth to 6 weeks, and then complementary feeds, but no mixed feedings. And we monitor the growth and development. Immunization is very critical. And one more thing which I would like to say is early infant diagnosis, especially from 6 weeks of birth onwards. We monitor the child periodically and systematically from 6 weeks, 6 months, 12 months, and at 18 months. We confirm the status of the child only at 18 months, but we monitor and we do early infant diagnosis, the DBS testing, starting from 6 weeks. And I take the exclusive replacement feeding as the last, because we usually in Karnataka and even in India, majority of the states, we propagate and advocate only exclusive breastfeeding. Exclusive replacement feeding only if AFAS criteria is met: accessibility, feasibility, affordability, sustainability, and if it is safe, only then we advocate for replacement feeding. Especially in medical colleges, the pediatricians advocate for replacement feeding, but we as practitioners and program implementers, we always advocate for breastfeeding. You can just see, because the deaths due to other illnesses apart from HIV is more commoner in children who are replacement fed than breastfed. So one more very critical thing is do not suction, do not milk the card, and as I said, no mixed feeding. So irrespective of the child's HIV status, the breastfeeding is continued up to 24 months or beyond. Once the child is found to be positive by early infant diagnosis, we ask her to continue breastfeeding. So by like any other child, the child is asked to be breastfed. So now coming to the ARV prophylaxis, as I told you in my previous slides, you all know that 3-drug regimen is given to the mother, and I also said that nevirapine prophylaxis should be given to the child. So starting from birth to 6 weeks of age, the child should be given nevirapine prophylaxis, but there is extended prophylaxis which is given. I'll come back to this here. So if the mother has taken ART for more than 24 weeks, we just mentioned, if it is yes, then we say the nevirapine syrup has to be given only for 6 weeks. If the mother has taken ART less than 24 weeks, then we say that the child is advocated nevirapine for minimum 12 weeks. So if the infants of women with prior exposure to single dose nevirapine, or the mother is having HIV-2 infection, then the child will receive syrup zidovudine in place of nevirapine. So this is very critical. As I said, 3-drug regimen for the mother and syrup nevirapine for the child for 6 weeks and 12 weeks, depending on the ERT treatment for the mother. And for those mothers who are having HIV-2 infection, and if the mother is exposed to nevirapine in her previous pregnancy, then we give syrup zidovudine to the child. And we also give cotrimoxazole prophylaxis to the child starting from 6 weeks. From birth to 6 weeks, you all know, you give nevirapine syrup, whereas after 6 weeks, we start the child on cotrimoxazole prophylaxis. So when do we start, when do we stop is very critical. So you do the HIV status, you do the HIV testing to the child at the age of 18 months. If the child is found to be positive, you continue cotrimoxazole prophylaxis till 5 years of age, starting from 6 weeks of age to 5 years of age. If the child is found to be negative, you stop cotrimoxazole prophylaxis at the age of 18 months. So this is very important. So pupillicity care continuum, you all know the mother and baby should be placed on ERT and ERV prophylaxis. And early infant HIV testing is very critical. We do the dry blood spot test as the test for early infant diagnosis in children. We start from 6 weeks. We do 2 tests. If it is found to be positive, we place the child on ERT. And if the child is negative, then we call the child back again at 6 months and we repeat the test. We do the antibody test initially, and then we do, if the antibody test is positive, we do the dry blood spot test. If that is positive, then we put the child on ERT. If it is negative, we call the child back again at 12 months. Similarly, if it is the same strategy holds good, again at 18 months, whatever said and done, we do the testing at 18 months. If the child is found to be positive, we continue the treatment. If it is found to be negative, we call it as discordance, and we do other tests like viral load testing, we do ELISA testing, and we do TNA PCR testing, total nucleic acid testing. So this is very important. And next is retention and monitoring, especially the mother and child is placed on ERT. We should ensure that they retain and they monitor, and the child and the mother is monitored properly. And final HIV status, as I told you, at 18 months of age, we should ensure that the mother is taking lifelong ERT, and we should be link them to the well child care clinics. Now coming to the elimination of mother to child transmission of HIV for a HIV-free generation, where are we? So we do have the criteria. We have impact criteria as well as the process criteria. The impact criteria for HIV, mother to child transmission, less than 2% among the non-breastfeeding population and less than 5% in the breastfeeding population, and case rate of less than 50 per lakh live births. This is the impact criteria to say that we have eliminated mother to child transmission of HIV. Whereas for syphilis, we have case rate of less than 50 per lakh live births. And the process criteria for both is ANC coverage should be more than 95% in the state, testing coverage should be more than 95%, and ERT coverage should be more than 95% for both HIV and syphilis. As I told you, we are looking at triple elimination in Karnataka for both, for the 3 diseases, HIV, syphilis, as well as hepatitis B. And this criteria have to be met in at least one low performing subnational area with regard to human rights and conducive laws and policies. So I would like to say that Karnataka has taken up the step forward, and we have done this validation of elimination of mother to child transmission of HIV. Two districts were selected. One was Shimoga and one was Bangalore Urban. Bangalore Urban being a low performing district, whereas Shimoga being a high performing, because we had 100% ANC testing and 100% coverage there, whereas we had 50 to 60% coverage in Bangalore Urban. So this was the validation criteria, and we were eliminated. We were validated for these 2 districts, and finally we are yet to get the important validation diagnostic criteria from NACO, and we are awaiting because of the COVID situation. We are held up this year. Otherwise, probably Karnataka would have been in the map of elimination of mother to child transmission of HIV. So India's commitment to EMTCT, India is committed to achieving the goal so that no child is born with HIV. Target for process indicators for validation, as I told you. But here we are looking at 95%, 95%, 95%, not 90, 90, 90, as I said earlier. This is 95% of all estimated pregnant women are registered for ANC and receive at least 1 ANC checkup. And out of this, more than 95% of the estimated pregnant women are tested for HIV. and more than 95% of all HIV positive pregnant women are placed on ART. This is the criteria which we are looking at. So what is the application? How do we apply for validation? This impact target should be met out for at least 1 year, process target for 2 years. So we are almost there. Elimination has been achieved in at least one lowest performing subnational administrative unit. So for Karnataka, we took Bangalore urban as the lowest performing one. Existence of adequate validation standard, we do have monitoring and surveillance system, both in the public as well as private. And we do have validation criteria met and consistent with the human right consideration and sustainable university programs and services. So this is what is the process for application. What is this process of AMTCT validation? First and foremost, we go through the process criteria and the impact criteria. Then the national program achievement of EMTCT targets. For example, if Karnataka has achieved the targets, we write to NACO, National AIDS Control Organization. National AIDS Control Organization writes to the global regional validation site or the committee, and they come and validate us. And then finally, if we pass the impact criteria as well as process criteria for minimum of 1 year and 2 years, then probably they give us the elimination certificate saying that okay, Karnataka has eliminated the mother-to-child transmission of HIV. In case if you fail to do that within those 2 years, and if we go back again by a step behind, then the validation certificate will be withdrawn. So this is the process of EMTCT validation. Now, coming to the data for the state, the Karnataka Pupicity cascade for the HIV, you will come to know like where are we standing here. The estimated number of mothers needing prevention of mother-to-child transmission of HIV was 1390. Approximately 1,390 positive pregnant women should be identified this year. But this is the last year's data which I'm showing you. Diagnosed positive mothers were 1,050. We were able to diagnose only 73 to 75%. Out of which 98% were placed on ERT. This is very good. Among the diagnosed, we are placing everybody, almost 98% of them on ERT, and 92% of them, that is 927 infants, were born to the positive mothers, out of which 100% of them were placed on ARV prophylaxis, and 96% of them, out of 927, 892 children received the testing at within 6 months of birth, and 18 children were found to be positive last year. This is again a leaking cascade. 1 second, can you please? Yeah. This is the leaking cascade, which I say that because out of 927, 29 infants were reported deaths and 6 babies were lost to follow. And out of 18 infants, we placed 15 children on ERT, whereas 1 was lost to follow up and 2 migrated. So you can just see this is, we were supposed to be targeting 1390, but we could only get 1,015. This is again a big leak here. So, but later on the leak has reduced, but still this is a big leak, but this is the need which we are supposed to be looking at. So only if we achieve this, probably we will be achieving our 95, 95, 95. This is the categorization of districts based on PMTCT need estimates. So these are the districts like Bangalore Urban and Belgaum, which are the high burden districts. We are expecting to have more than 200 positive pregnant women this year. And these are the districts like Bagalkot to Tumkur. These are called the medium to low burden districts, where we expect somewhere around 100 positive pregnant women. And Bangalore rural to Yadgir as low burden to less than approximately 50 positive pregnant women this year. So totals up to around 1,390 positive pregnant women we should be testing, and we should place them onto ERT this year. And 17 countries have been certified elimination of mother-to-child transmission of HIV. I would like to see my country. Cuba, Thailand, Armenia, Moldova, Belarus, and these countries, Malaysia, Maldives, Sri Lanka, all these have achieved. Moldova has not achieved in HIV, but definitely for other, even for syphilis, all the other countries have achieved for an HIV-free generation. So India, we are just hoping and we are keeping our fingers crossed. Can we? Yes, we can. And there are certain challenges. As you all know, COVID-19 pandemic crisis. So the essential services were definitely, hampered this year because of the COVID-19 pandemic. As Dr. Poonam was also saying that. And reach PMTCT need, especially our goal is to reach 1390, but we have diagnosed only 1,015, 73% of them last year. But we are keeping our fingers crossed, and we are trying our level best to achieve this year. Because of the COVID, we don't know whether we could achieve that too. And we need to strengthen the referral and linkage mechanisms, especially with regard to ICTC and ERT. There could be a loss to follow up from ICTC to ERT, that is very critical, and from public to private, and from private to public also there could be a linkage loss. And especially early registration the first trimester, as you all know, the mothers usually, especially in the rural areas, they come in the second or third trimester. Again, it is becoming very difficult for us to ensure early trimester testing and putting her on ERT. If we put her on ERT in the first trimester itself, then it is easy for us to ensure that the transmission doesn't take place from mother to child. And next, HIV known positives and follow-up reporting. The mother could be, she would be taking ERT and she would have become pregnant now. But again, the reporting mechanism is becoming very poor, especially for those for known positives. So that is very important. This is again a big challenge for us in Karnataka. And institutional deliveries for positive mothers in the same hospital. As we all know, the mothers go from husband's place to her parents' place for delivery. Again, ensuring our institutional delivery and follow-up especially becomes a big Herculean task. There could be a duplication. She could be registered in one center and she'll be getting tested somewhere and delivering somewhere, and that could be again a big challenge. Early infant diagnosis uptake, again, as I told you, 6 weeks, 6 months, because it's a periodic and systematic follow-up. Again, that's a big challenge. Many of the mothers won't bring the child at 6 weeks for testing. They usually come after 6 weeks. Again, as early as possible, if you test the child and place the child on treatment, it will be very easy for us to ensure elimination. Syphilis testing and reporting, though we claim that we are testing 100% pregnant women for syphilis, but again, reporting is a big Herculean task, and that is a big challenge. And regular reporting is time and resource intensive, and again, this is because every time we have different formats and different softwares coming up from NACO. Again, reporting is very time consuming and resource intensive. And the support required to ensure elimination is creating enabling environment for both mother and baby to services free of stigma and discrimination. As you all know, earlier there would have been more of stigma and discrimination, but as times evolved, and now we have shared confidentiality, and the stigma and discrimination has reduced to a maximum level. And providing essential counseling services for positive pregnant women. Again, this is very, very essential. And we should ensure ARV prophylaxis for exposed child, especially as I told you, as early as possible, we should test the child and put the child on treatment. Especially for those children who are HIV exposed, we should put the child on ARV prophylaxis before we test the child. So 6 weeks from birth to 6 weeks minimum, we should ensure ARV prophylaxis. Ensure AFAS criteria. Again, I'm not very happy with this replacement feeding at all, so I don't want to comment on it much. And early infant diagnosis, 6 weeks, 6 months, 12 months, 18 months, periodic and systematic follow-up of the early of the child is very, very important. So Karnataka, again, I'm happy and proud, and with all the support of our private partners and SVYM and other stakeholders, and even in medical colleges like you people, Karnataka is leading the way towards elimination of mother-to-child transmission of HIV, and Karnataka was adjudged as the best, AIDS control society in appreciation for commitment towards elimination of mother-to-child transmission. This is the certificate, and this is the memento which we received last year, and ours was the first state to receive this. And you all know, talent wins games, but teamwork wins championships. So our program needs focus and not the limelight. So for every child, the mother is its world. So let's join hands to create a safe and healthy world for them. With all your support, I really think that we could achieve elimination agenda, and we can eliminate mother-to-child transmission of HIV in Karnataka. Thank you so much.
Thank you so much, madam. It is a great privilege to have listened to your very informative and enlightening lecture today. So on behalf of the entire department and our institute, I extend a warm. I would like to extend thank you to you. I would now like to request if the participants had any doubts or questions to be clarified. The platform is open for discussion now.
I'm audible. Sorry, I rejoined. There was some technical glitch here.
Yes, yes, ma'am, you are audible.
Dr. Navya?
Yes, ma'am.
Yeah. Uh, as there are
No
I think,
question.
yeah, clarifying questions. So it was really an informative session, Dr. Lalita. Thank you very much. It was really a pleasure having you with us. I request Dr. Navya to please propose the vote of thanks.
Am I audible?
Yes, Navya.
So it is my pleasure to propose the vote of thanks on this occasion. I express my sincere and heartfelt gratitude to the Honorable Chancellor of Yenepoya, Deemed to be University, Yenepoya Abdullah Kuni, and Pro-Chancellor Farhad Yenepoya for their constant encouragement and support. I express my heartfelt gratitude to our Honorable Vice Chancellor Dr. M. Vijay Kumar and Registrar Dr. Gangadhar Somyaji for extending their constant support and motivation. I would like to thank Dr. M.S. Musaba, Principal, Yenepoya Medical College, for delivering his support as always. I would like to express my gratitude to Dr. S. Padmanabha, Medical Superintendent, Yenepoya Medical College Hospital, for providing the opening remarks on the program today. I would like to thank our Vice Deans of Yenepoya Medical College, Dr. Abhay S. Nirgude and Dr. Ashwini Dutt, for their unconditional support and guidance. I would like to express my gratitude to the senior faculty and its various departments for being part of this event. I would like to thank our guest speaker, Dr. Lalita Hande, State PPTCT and Maternal Health Consultant, UNICEF, Government of Karnataka, for delivering the very informative and enlightening lecture today. Special thanks to our PG alumni, Dr. Nishchit KR, who is working as a WHO consultant for National TB Elimination Program, who was responsible for liaising between the Department of Community Medicine and Dr. Lalita Hande. I would like to thank Dr. Poonam R. Naik, Professor and Head, Department of Community Medicine, for her initiative in observing the World AIDS Day and delivering the special lecture on the World AIDS Day theme. I would also like to extend my sincere gratitude to the staff, both teaching as well as non-teaching, and the postgraduates from the Department of Community Medicine and efforts in organizing this program. My sincere gratitude to Mr. Deepak and the IT department for their most valuable technological support. My sincere gratitude to our photographer, Mr. Hassan Sheikh, for covering the program. I would like to specially mention Dr. Malvika and Dr. Vinita, postgraduates in the Department of Community Medicine, for the help extended by them in conducting this program today. Finally, I thank each and everyone attending the webinar, both in Google Meet and the YouTube platform, for making this event a successful one. Thank you all. The feedback link is being posted in both the YouTube comment box as well as in the chat box. So I request all the participants to kindly fill the feedback form. And as soon as you fill the feedback form, you will receive the e-certificate for this program to your email address, which is mentioned in the feedback form. Thank you all.
Thank you, Poonam. Thank you, Navya. Thank you, entire team. I'm so sorry. I was getting too many calls because we are rolling out the COVID vaccine. So we are very, very busy with all other stuff. So thank you so much.
Thank you. Thank you.
Yeah, thank you, Dr. Lalita. It was really an enlightening session for all of us. I'm sure all the participants would have had a fruitful learning. Thank you for this.
Thank you.
Thank you all participants.